Hello and welcome to another episode of Vital Times, the CSA podcast series. I'm Dr. Ludwig Lin, and I am super excited and very honored to be able to invite Dr. John Finneran to this podcast interview. Dr. Finneran is an associate professor at University of California, San Diego, and we are going to talk about cryoneurolysis today. He completed his residency and fellowship training at UC San Diego and now serves as the associate program director of the UCSD anesthesiology residency program. Dr. Finneran's research areas of interest include regional anesthesia in trauma and burn populations, phantom limb pain, and cryoneurolysis and electrical stimulation of peripheral nerves. Welcome, Dr. Finneran, and let's get the logistics out of the way first. Do you have any financial disclosures to declare?
Yes, some of my research has been funded by a variety of companies that make peripheral nerve stimulators, cryoneurolysis devices, and pumps for continuous peripheral nerve blocks. All of that funding is provided directly to the University of California, so I don't receive any sort of money for any of the research that I do. And I don't do any sort of paid consulting. But my research has been funded by EpiMed, which is a cryoneurolysis manufacturer, SPR Therapeutics, which is a peripheral nerve stimulator manufacturer, Massimo, which makes peripheral nerve stimulators as well. And then Infutronics and Avanos, Infutronics and Avanos, who make pumps for continuous peripheral nerve blocks.
Got it. Thank you for making us aware of that. And obviously, this type of clinical work requires a lot of new technology, so that makes sense. During this podcast, I would like to cover the basics of cryoneurolysis with you and, just like really learn from you and also raise some thought-provoking questions for our audience. So things like, indications, contraindications, potential short and long-term complications. So let's just start with the basics. Let's talk about the theoretical mechanism of action that makes cryoneurolysis work.
Yeah, absolutely. Just sort of to back up, the main benefit of cryoneurolysis is very long duration analgesia. And the mechanism by which that occurs, at least, the theoretical mechanism, is Wallerian degeneration. So we all learned about this in medical school. Essentially, when axons are injured, they degrade from the point of the injury to where they terminate. And then, assuming that the surrounding tissues are completely intact, those axons regenerate at a rate of about 1 to 2 millimeters per day. And so the duration of the block that you get is proportional to the distance between where you do cryoneurolysis and wherever those nociceptors are that are being activated.
Wow, that sounds like some exact clinical work that's happening there. Okay, so let's talk more about that. So that's the mechanism of action, and how do you make that happen? What kind of equipment do you use? And how does that equipment actually achieve this?
Yeah, all cryoneurolysis devices that are currently cleared by the FDA basically have the same general properties. So the cryoprobe is what you actually put into the patient. It looks basically like a large needle. And we do this usually under ultrasound guidance. Within that probe, it's sort of a tube within a tube. So you have a gas that flows down the center tube, and that gas is at high pressure. So it's usually nitrous or argon, or another high pressure gas like that. It gets to the tip of the tube, and then within that probe, there's an annulus that it goes through. And so once it goes through that annulus, the pressure dropped. Remember, it's coming from a very high pressure source like a nitrous or argon tank. The pressure drops, and the drop in pressure is what leads to a drop in temperature. So if you just sort of like take the probe and put it into saline, which is what we'll often do to test the probes right before we use them, you actually see a ball of ice form around the tip. So nothing actually is injected into the patient. It is just that the tip gets so cold that whatever is around it, whether it's in saline, and the saline forms ice, or in the patient and the tissue around it freezes, whatever is around the tip gets frozen. And then because it has sort of a tube within a tube, the gas exits through the surrounding tube, and usually is vented into the room. So, in terms of what the machine is, you have the probe, and it's connected to a machine that regulates the gas. And these machines fall into basically two categories. There are handheld machines. There's actually only one on the market. And those are nice because they're portable. The initial cost is relatively low, but they can be somewhat cumbersome in your hand. And since it has these little nitrous canisters that are not reusable, the cost per use is relatively high. Then you have machines that are sort of console-based machines, where your probe is connected via tubing to these machines that are connected to nitrous or argon tanks. And those ones are, less portable and more expensive. But if you have ones that have reusable probes, the cost per use can be, as cheap as whatever it costs to autoclave your probe in between uses. So that's sort of what the general equipment is for cryoneurolysis.
Got it. I'm beginning to picture this. So let me ask you a follow-up question about the equipment and how you use it. So you said that you tend to use it along with an ultrasound machine. So you were using both this probe attached to its machinery, and then you have a ultrasound probe with the display for the ultrasound next to it, so that you're
Exactly.
visualizing
Yeah.
what you're doing. Okay.
Yeah.
And
And
yeah, go ahead.
oh, sorry, I was just gonna say, you need some sort of, just like any pain or regional anesthesia procedure that you do, you need some mechanism of guiding your probe to your target, right? So there are, this has been used, or I should say, cryoneurolysis, or percutaneous cryoneurolysis, has been done with ultrasound guidance, with fluoroscopy, CT. It can be any sort of guidance, but especially for us in regional anesthesia, we're very good at placing, needles right adjacent to peripheral nerves. And so that is, what we usually use.
Great. That totally makes sense. And I have yet more follow-up questions about that for you. So,
Sure.
um, I, uh, I was trying to do a little bit of preparation for this, and I am myself a regional anesthesiologist. I love it, and I actually trained during the era of electrostimulation. So I had to learn ultrasound, but it's been great, and I think it's it gets us closer to the nerves, it's accurate. And it sounds like that actually is very helpful for cryoneurolysis because the effect of it improves when it's closer to the nerve. Is that correct or incorrect?
Yeah. So when cryoneurolysis was first being performed, the first reports are in the 1970s, done through open incision. So it was being used for freezing intercostal nerves in patients who are having thoracotomies. And we can talk a little bit more about that later. But the first percutaneous probes were developed in sort of like the late 70s and early 80s. And yes, absolutely, nerve stimulation is another mechanism that can be used to localize the nerve. In terms of the placement of the probe, yeah, it is ideally positioned as close to the nerve as possible. So what sort of happens is that as that ball, we call it an ice ball, and it looks very much like this frozen ball when we see it on ultrasound. When that ice ball or frozen tissue is forming at the tissue around the probe, as it forms ice, it also insulates the tip. And so you do want it to be as close to the nerve as possible because you really need to expose axons to a temperature range that's sort of in the negative 20 to negative 100 degrees Celsius range if you want that sort of Wallerian degeneration. In the 0 to negative 20 range, you get like a neuropraxia that's only going to probably produce a block that is hours in duration.
Got it. So, in terms of making sure that you do reach that temperature of negative 20 Celsius to negative 100 or 110, um, you're not using some method of directly measuring the tissue temperature. You're looking for that presence of the ice ball as a proxy. Is that right?
Yeah, exactly. So the gases that we use tend to freeze, or they freeze tissues to a certain temperature. So if you wanted to do cryoablation is used for a variety of reasons in medicine, especially in interventional radiology. And if an interventional radiologist wants to ablate and destroy a tumor, they want to get it much colder than negative 180 degrees. And so they'll usually use xenon gas, and that can freeze to much colder than negative 100 degrees. Um, at those temperatures, you can get uh, more injury or greater degrees of nerve injury than we want with cryoneurolysis, right? So if with cryoneurolysis, our goal is, if you think about like the Sunderland grading system, a Sunderland 2 class injury where the axons degenerate but all the surrounding tissue remains intact. If you get it too cold by using a gas like xenon, you potentially can damage those surrounding tissues and have the potential for neuroma formation or even like transection of the nerve. But yeah, it's mostly dependent on the gas that we use. It's a physical property of the gas how cold it gets.
Got it. Let's talk a little bit more about the way or ways you can manipulate each particular case to influence things. For example, how do you influence the duration of action? Are there variables that could help you increase the efficacy and increase the or prolong the effect?
Yeah, so I mean, it's sort of a binary. Either have cryoneurolysis or you don't. It's not like with local anesthetics where you can give less concentrated dose and have less of a block, right? You either have that axonal injury or you don't. And so you can't influence the duration or the degree of block really in any way other than by trying to be as proximal as possible, right? Because we said that, the duration of the effect should be largely dependent on the distance between where you perform the procedure and where those peripheral nociceptor endings are.
Right, because that segment all needs to regrow before
Exactly. Yeah.
the sensations come back.
Yeah. And in terms of, increasing the efficacy, um, like we said, we want to have the probe tip as close as possible to the nerve, so that the nerve gets frozen. What you probably end up with is sort of like a mixed injury picture with sort of a like bimodal distribution in terms of when nerve function returns or when axon function returns, right? Within any peripheral nerve that you freeze, not every single axon is going to undergo Wallerian degeneration. So,
Hmm.
you're going to have some axons that just have this sort of transient neuropraxia and the function will return, probably in hours or days. Then other axons that undergo Wallerian degeneration, and, the function should return over the course of weeks.
Cool. So I feel like I had read that some people will actually freeze along points of a nerve. Am, am I making that up? Is that, do people do that?
What do you mean? Oh, like
Like,
at multiple points?
yes, you only do one
Yeah.
spot.
So, well, yeah, for a couple reasons, right? There's this idea of a double crush phenomenon that is, as you subject a nerve to more injuries, those injuries sort of the effects potentiate each other. So I probably wouldn't treat a nerve at multiple points. That being said, I don't know of any data in the literature to suggest that would have any sort of detrimental or beneficial effect.
Hmm. Okay, okay, good. So that actually makes me want to ask you yet another question about this.
Sure.
Obviously, you can tell that I'm fascinated, which is
Yeah.
why we're talking. So I feel like as a regional anesthesiologist, we like to be quite, specific and block as distally as possible. In a way,
Yeah.
it sounds like the paradigm is entirely opposite in terms of getting cryoneurolysis to work. You wouldn't be doing, for example, like a ulnar nerve block. You'd be going up. Well, not that we would be doing this on the brachial plexus anyway, but it's like, for example, you'd be going a little bit more proximal than like one distal peripheral nerve, or is that possible?
Yeah, so it really depends on the clinical scenario, and it sort of is leading us into what clinical scenarios, or the clinical scenarios for which cryoneurolysis is potentially useful. Um, we have done, and it has been, and we have reported in the literature, I should say, uh, brachial plexus cryoneurolysis for patients who are having upper extremity amputations. And what we're sort of getting at is you potentially can create a very long lasting motor block. And so cryoneurolysis really isn't something that you would want to use if you could potentially have a very long duration motor block induced, and that wouldn't be acceptable in the clinical scenario.
Right.
So with regards to your question of ulnar nerve cryoneurolysis, if, for example, someone was having, had a fifth digit amputated, and they or had a fifth digit amputated, um, and was having terrible pain in that distribution. Well, actually, an ulnar nerve block would potentially be a reasonable thing to do, and I have done it in those situations. um, I wouldn't give that person, I wouldn't do a cryoneurolysis block of that person's brachial plexus because they'd lose, all the rest of the function in their hand, or sorry, their upper extremity. In a situation like that, I'd just say be really cautious. And what I usually do in a situation like that is do a local anesthetic block of the nerve. Maybe with like 0.5% bupivacaine or something, let them sit with that for 24 hours or so and decide, is this something that I would want for weeks or months, right? Because the ulnar nerve is a great one to ask about, because it does innervate a lot of the intrinsic muscles of the hand, and even if you do a really distal block of it, they're gonna
Hmm.
lose grip strength, right? And so if
Hmm.
what you're trying to do is get them back to their activities of daily living, they might be fine. They might be worse off not having the grip strength, and not having pain.
Right, right. Um, I want to ask you more about that, like your favorite indications. But before that, I'm going to go off on a tangent and ask
Sure.
you to define a couple of words for me. So we've been talking a lot about cryoneurolysis, and I think that is self-explanatory because you are, in a way, lysing these axons, and it takes them weeks to, like maybe months to regrow. So then that makes sense. It sounds nicer to me to talk about cryoanalgesia, but that almost sounds more like the neuropraxia you're talking about. So I just wanted to ask you about how these terms came to be, really.
Yeah. So the term cryoanalgesia basically just it means exactly what its roots would suggest.
Yeah.
Using cold to produce pain, cryoanalgesia, to treat pain, cryoanalgesia, right? And this concept of using cold to treat pain is ancient and intuitive to us, probably because it is so ancient, right? You look at like writings from ancient Egypt, and you find reports of using cold to numb people's extremities, or to numb areas where incisions would be made. This has been used for millennia, right? But it's also a very general term, right?
Mm-hmm.
Um, any sort of use of cold to relieve pain, right? So cryoneurolysis is a form of cryoanalgesia, but it really refers to the specific technique of freezing peripheral nerves to reversibly ablate their function.
Got it. And yeah, that is perfect. And if somebody actually needed something permanent, then you would use something colder, but then you
Yeah,
also run into potential complications like a neuroma because now you form some scar tissue. So
exactly.
yeah.
Our chronic pain call and interventional radiology colleagues have lots of techniques that they utilize for permanent
Hmm.
ablation of peripheral nerves. But cryoneurolysis is good. It's sort of the intermediate between, the duration that you can get with any sort of local anesthetic blocks. At most, you can get days from continuous peripheral nerve blocks. But if you don't want a permanent treatment of that nerve.
Perfect. Thank you for that. So yes, let's go on and talk about indications. So what are some of the what are some of your favorite clinical applications for this technique?
Yeah, right. So, like we said, any situation in which a very long duration block would be favorable, and a motor block would not be unfavorable, right? So either nerves that have little or no motor function, or nerves that where after a surgery that the patient is having will no longer innervate large muscles. So, in the former group, something like intercostal cryoneurolysis for mastectomy or rib fractures, or lateral femoral cutaneous nerve cryoneurolysis for skin graft donor sites from the lateral thigh. Or in the latter group, you have things like people who are having amputations, and you would certainly never consider doing a sciatic cryoneurolysis for someone who is going to have an ankle fracture fixed, right? Because they need the function of all of the muscles in their leg and foot, right? But someone who's having a below knee amputation, you potentially could do cryoneurolysis of their sciatic nerve. In terms of my favorite, probably my favorite one, just for no specific reason, is that I do really like doing cryoneurolysis of the lateral femoral cutaneous nerve for split thickness skin grafting. We do this. We do a lot of these surgeries at the Hillcrest Hospital in San Diego because we're a big burn center. And we do a lot of regional anesthesia in general for our burn population. But it can be really nice to give people, a numb area of their thigh where a skin graft is going to come from, because skin grafting hurts a lot and
Hmm.
for a long time.
Hmm.
And the lateral femoral cutaneous nerve is a great target if you don't need a tremendous amount of skin, because it has no motor function. And the reality is, people don't even really seem to notice the numbness that they have there, um, because it's such a small area that people don't really think about. But when they have pain there, they really, really notice it.
Right. And that seems like a really wonderful way to improve somebody's quality of life. So
Yeah,
let's talk
absolutely.
about, yeah, so let's talk about um, contraindications and potential complications. There's a whole
Sure.
list of the, like the usual potential contraindications, like vascular,
Yeah.
etc. But tell me
Yeah.
more about some of the things that you really worry about.
Yeah, all right. So, like you said, I mean, same. I mean, the main contraindications are the same as any percutaneous regional anesthesia or pain procedure, but there are a few that are specific. Basically, cold activated pathologies. So things like cold urticaria, Raynaud's disease, cryofibrogenemia, cryoglobulinemia, paroxysmal cold hemoglobinuria, those sort of diseases, or those sort of disease states, are contraindications to having cryoneurolysis. And it seems it's intuitive, right? That anyone who has a pathology that is activated by cold, you shouldn't be introducing freezing temperatures into their bodies. Um, but in terms of like the safety, one of the things that people worry about is, like, if you do this on nerves that are close to vascular structures, could you potentially, by freezing the wall of the blood vessel, cause rupture of the blood vessel? And there actually are studies that have looked at this, at applying much colder temperatures to the walls of blood vessels for much longer. You can actually apply temperatures that are in the range of negative 200 degrees to the walls of veins and arteries for several minutes. And because there's so much blood flowing through them, it basically acts as like a reverse heat sink. It brings heat into that area,
Ah,
and so you
yes.
really don't have to worry. Even if you see the wall of a vessel encompassed in your ice ball, you don't have to worry that you're going to induce, coagulation there or rupture the wall of the vessel.
That's really good
That
to
being
know.
said,
Yeah.
I wouldn't do this in any patient who was profoundly coagulopathic, right? If you wouldn't do a peripheral nerve block in someone,
Hmm.
I also wouldn't do cryoneurolysis.
Right. Right. Well, I haven't seen this, but it sounds like the needle caliber is probably a little bit wider than what we're using for our ultrasound guided blocks?
Yeah, so it depends on what machine you're using, but the gauges for cryoneurolysis probes are usually between about 20 gauge and 14 gauge.
Okay. Yeah, so slightly bigger.
Yeah,
Let me ask you about complications
sure.
of this procedure. So, like immediately my brain thinks about um, injury um, to the axons and the membranes. And we all know that pre-existing injuries could complicate things as nerves try to regenerate. I am not a chronic pain person, so I start sort of getting very anxious when I start talking about this, but there are reflex pathways that get formed. So, what happens to patients like that who undergo cryoneurolysis?
Yeah, so I mean that's a great question, and one of the things that that some people are worried about is like diabetics, right? So we know from lab studies, we know from in vivo studies that diabetics have impaired axonal regeneration. Um, what I can say is there's no evidence in the literature that diabetics respond any differently to cryoneurolysis compared to people who are non-diabetic. And in fact, there are case series in the literature of utilizing cryoneurolysis for patients who have chronic neuropathic pain related to diabetes. Um, Diabetes or other peripheral nerve issues haven't been exclusion criteria for any of the major randomized controlled trials for cryoneurolysis. And like I said, there, as far as I am aware, no reports in the literature of any patients who either are chronic pain patients or who are diabetic or who are have any other nerve regeneration issues uh, having worse or for that matter better outcomes because you could hypothetically say that if someone has delayed axonal regeneration they potentially would get longer lasting benefit from cryoneurolysis. But as far as I know, there's no evidence in the literature to suggest that those patient populations have any better or worse outcomes with cryoneurolysis.
Okay. Well, that's very interesting, first of all, and second, it's good to know that for now we haven't seen anything, and
Yeah, absolutely.
sometimes time will tell. As a
Yeah,
follow,
and
yeah,
and
oh, go ahead.
sorry. What I was just going to say was,
Yeah,
it's why we do randomized controlled trials, right? That and why we keep doing like
yes,
more trials and larger trials and repeating trials that have been done, so that we pool data and especially rare complications are a reason to repeat trials and to do larger trials because we certainly always want to make sure that we first right do no harm to people.
exactly. Um, yeah, let me follow up on this with something that I read in your excellent review of this topic. Um, Thank you for writing that. And
Thank you.
I think you had written about some a phenomenon seen in people who got cryoneurolysis through the open approach,
Yeah.
where perhaps the double crush theory was in evidence. So tell us more about that.
Yeah, exactly. And that's sort of what I was alluding to earlier. So the first reports of cryoneurolysis for pain control were in open thoracotomy patients. So if you can imagine, like obviously the chest wall is exposed, and what the surgeons were doing in those cases was dissecting out the individual intercostal nerves, picking them up with forceps and applying cold, by various mechanisms to the nerves. And the results of these studies were mixed, but they did find at least some of them did find increased incidence of new neuropathic pain when they were doing this. And what we think happened is that the degree of trauma when you surgically expose and then with forceps pick up and pull out a nerve and then freeze it, it is a much greater injury. And like we said, there's this idea of double crush phenomenon that multiple injuries potentiate the effects of one another. So there definitely, or there seemed to be an increased incidence of new chronic pain when open surgical cryoneurolysis was done. Encouragingly, there are no reports in all of the literature of new chronic pain following cryoneurolysis when done percutaneously.
I think that's very encouraging support for the technique of percutaneous cryoneurolysis. So that's great. It does make me wonder why we don't see this in in patients with pre-existing neuropathic pain who get cryoneurolysis. Is it that we just haven't done this enough? What do you think, John?
I think it's hard to say. We do this clinic. We do cryoneurolysis clinically for people who have chronic post thoracotomy pain, for people who have chronic post mastectomy pain, and they respond well clinically. And actually, for some individuals, and we've published a small case series on this. If they get benefit, that lasts for several months from cryoneurolysis, and then the pain comes back, you potentially can give them a longer lasting treatment like radiofrequency ablation of the intercostal nerves. If every few months they're getting cryoneurolysis and getting benefit, but the pain comes back. We haven't seen anyone who had worsened pain, but it's definitely something that still needs to be studied. That we should be keeping track of what we're doing. We are doing much larger multi-center randomized clinical trials now, these kind of trials are going to be better for picking up rare complications. So I'd say hard to say right now, but the evidence doesn't suggest that even people who have chronic pain in the distribution of their injury, that they are susceptible to, or that they are, likely to get worse chronic pain after having cryoneurolysis.
Good, good. This is so fascinating, and I can't wait to hear more. One additional clinical question I wanted to ask you about in terms of a variable is, um, do people benefit from getting adjunct medications while they're doing this? And do adjunct medications or concomitant medications impact the way this block performs over time? I'm thinking about things like the gabapentinoids. Maybe they don't actually
Sure.
influence things.
Yeah, it's hard to say. I don't think that there's any evidence in the literature to say one way or the other. If utilizing gabapentin is going to have any effect on the outcome. Usually in our clinical practice as well as in our studies of cryoneurolysis, we have patients get all normal standard of care medications. So, if they would normally get gabapentin or scheduled acetaminophen after their surgery or related to their trauma or burn, they still get that. So, I mean, I think that like all things that we do in regional anesthesia and pain, there should be a very multimodal approach. And so I would advocate utilizing other adjuncts as well when you're using this, just like I would for anyone who had a local anesthetic based peripheral nerve
Right,
block.
right.
Um, it does sort of bring up the question of whether or not to do local anesthetic nerve blocks when you do cryoneurolysis. And the answer to that question is we don't really know what whether you should do that, and we don't know if it makes a difference. In some of our studies, we have done active cryoneurolysis and sham local anesthetic compared to active local anesthetic and sham cryoneurolysis. In other of our studies, we've given patients normal standard of care peripheral nerve blocks. For example, we had a relatively large mastectomy study that was published in anesthesiology, where all patients got continuous paravertebral blocks with ropivacaine, and then people were randomized to either get sham or active cryoneurolysis. And so, we in our studies, we in our clinical practice do sort of a mixture of both. I would say that if you are going to do a cryoneurolysis procedure without much sedation or any sedation, you probably do want to do a local anesthetic block. As you might imagine, is somewhat uncomfortable. They do tend to get some sort of like, abnormal sensation. Sometimes they may describe it as pain in the distribution of that nerve if you didn't do a local anesthetic based nerve block before doing the cryoneurolysis.
Mm-hmm. That makes sense. Um, One more medication question for you. What about, for example, pulse steroids? Anecdotally, I know that some people like to use steroids because it's got some analgesic effects. However, it's also somewhat neuroprotective. And do you want to have neuroprotection happening when you're doing cryoneurolysis? Any thoughts on that?
Um, I would say that there is no, I don't know of any evidence in the literature to guide practice there. And, whether it's likely to have an effect, I think is hard to say. My recommendation to people would probably be do whatever your normal standard of care is as well, because you don't want anyone to not be receiving whatever your normal standard of care is.
Okay, good. Thank you. Um, I want to start to wrap this up, but I still have so many questions for you. First question I have for you is I feel like this is such incredible technology with amazing applications. Do you see this becoming more, widely applied and utilized and practiced by anesthesiologists?
Yeah, I think that it has the potential to be, but there are some big hurdles. We sort of mentioned one, which is the cost of the machines. So, there's, like I said, there's one handheld device on the market that costs, I think, somewhere around $5,000 or $6,000. But then, the probes cost several $100s and are not reusable. And the nitrous canisters that go in it cost several $100s and aren't reusable. So although you're looking at a fairly small initial investment, by medical standards, the cost per treatment is relatively high. And then, on the console based devices, you're looking at a very large initial investment in the 40 or more $1,000 range. With, at least if there are, if you're using a machine that has reusable probes, you can sterilize in between uses. But either way, you're looking at fairly high costs. So that's one of the hurdles. And then the other one is the time requirement. So we don't know exactly how long you need to freeze nerves for. There actually isn't I mean, almost nothing really in the literature on in terms of comparing different freezing protocols. Should you do multiple rounds of freezing? Should you do one long freeze? So that really needs to be elucidated in itself. But the time requirement can become quite substantial if you're talking about a lot of nerves. So, it's like on one hand, if you're doing a lateral femoral cutaneous nerve for a split thickness skin graft donor site, that probably takes you 15 minutes for the whole procedure. On the other side, on the other end of the spectrum, if you're looking at, you know, 4 or 5 intercostal levels on each side for a bilateral mastectomy, or 10 intercostal nerves for extensive rib fractures, you're talking about hours of treatment. And so, the time really becomes a limiting factor there. So there are actually, some potential ways to get around that. There are some devices where you can place multiple probes and then activate them all. So a lot of people might be familiar with sort of that concept from radiofrequency ablation, where you can like same exact thing, right? You place multiple probes and then you activate them all. But you're looking at, just like with RFA, very high cost for each of those probes, because usually if you are using a machine that has multiple probes, it's a relatively new machine and they're not reusable. And then there are some animal studies where investigators have injected a frozen glycerol slurry that is biocompatible, but stays frozen for a few minutes after injection. It's only been done in animals. There have not been human trials of anything like this, but it potentially could give you cryoneurolysis in basically a technique that would be almost identical to doing a single injection peripheral nerve block. So I'd say that is not in even in human trials yet, but a potential way around at least the time issues. So those I think are the two biggest barriers: the time requirements and the expense, because the technique itself is very, if you watch someone doing it, it's immediately familiar to anyone who does ultrasound guided peripheral nerve blocks. It is putting a needle or probe, in this case, adjacent to a nerve for a
Mm-hmm.
procedure. So I
Mm-hmm.
think it's easily incorporated into a regional anesthesiologist's tool set, but there are some big hurdles before I think it's going to become widely utilized.
Got it. Let's finish up by me getting you to talk about some of the research that you're doing in this discipline, if you can talk about it.
Yeah, absolutely. I definitely can talk about anything that is publicly available on clinicaltrials.gov. Um, we actually do have two very large studies that are funded by the Department of Defense. One is essentially repeating the mastectomy study that I mentioned, but in a multi-center fashion. So that is going to enroll several hundred participants, and it will compare local anesthetic, or I should say, all patients receive local anesthetic based nerve blocks, and then are randomized to active or sham cryoneurolysis. So that'll be really nice. When we did this study that was published in Anesthesiology, we did see a decrease in the pain scores, the opioid consumption, the presence and severity of pain all the way out to a year following surgery, following mastectomy. So it'll help to confirm those results, make sure that they are applicable across institutions, and like we said, larger studies are better for teasing out any sort of rare complications. So that's one of the big projects that we're working on right now. We just started recruiting patients, I should say participants, into another trial for rib fractures. And in that trial, we are comparing local anesthetics to cryoneurolysis head to head. So participants either get cryoneurolysis blocks or they get local anesthetic based blocks. And we're looking, at does this improve pain? Does this improve incentive spirometry use in the acute period, as well as out to a year? So those are our two largest studies that we're doing right now of cryoneurolysis.
Very cool. Well,
Yeah, we're very excited about them.
I am personally so excited about all of this, and I'd like to thank you once again for taking the time to talk to me and our listeners about a very exciting, not new, but yeah, increasing area of studies and clinical applications within regional anesthesia. And I think anesthesiologists can do so much good. And this sounds like an area that very much could benefit specific patient populations. So I'm definitely going to keep an eye out for your upcoming results. Thank you. And before we sign off, was there anything else that we have not discussed that you want to tell our listeners as takeaway points from this area?
No, I mean, I think that you did a wonderful job sort of leading us through that discussion. So I would just say thank you for having me. It was great to have this discussion with you. And I hope that people will find it, educational and sort of, hopefully somewhat entertaining and enlightening.
Definitely enlightening. Well, let me use this opportunity then to sign off to our listeners. This has been another episode of the California Society of Anesthesiologists Vital Times podcast series. Thank you for listening. Feel free to subscribe to the entire series, and we'll talk to you next time. Take care.